All right, we're going to do a little voiceover PowerPoint for chapter 19. I'm going to talk to you a little bit about some of the things at the beginning of this chapter, and then I have an additional video for you to watch of the physical assessment. So let's dive right in here. So this is just a quick picture. It's right at the beginning of the chapter, just so we understand the terms and what we're looking at and how the heart is situated. So you can see it's counting each rib as you go down, 1, 2, 3, 4, 5, 6, 7, 8. The pericardium is the entire area of where the heart lies. It's pointing to the base of the heart there, and that's where the heart is actually connected to all of the vessels. And then the apex is the very end or tip of the heart. So this slide is just a real quick reminder of the anatomy and physiology of the heart wall, the chambers, and the valves. Basically just a quick reminder that it has atriums on each side of the heart. They are more for just holding blood, and then the ventricles are the bottom part of the heart that really pump that blood either to the lungs or to the rest of the body. The 4 chambers, remember, are separated by those valves, and the valves only allow blood to move in one direction. They open and close in response to that pressure from the blood. And so the four valves in the heart, we have 2 AV valves and 2 semilunar valves. And you guys are familiar with those already. So the AV valves are the tricuspid on the right side and the mitral on the left. They are thin leaflets. They're anchored by some fibers there to keep the blood moving in just one direction. So these valves open up during the heart's filling phase, or when those ventricles fill with blood. And then when the ventricles squeeze, these valves slam shut so that blood does not regurgitate back into the atriums of the heart. There are some semilunar valves. Remember, those are in between the ventricles and then the arteries that leave the heart. Each of those have 3 cusps. The pulmonic valve, remember, this is on the right side of the heart, so meaning it's going to the pulmonary system. This valve will keep blood from regurgitating into the ventricle and not heading into the right direction of the lung. The aortic valve is the one for the left side of the heart that it passes through going into the body. And you can see there at the bottom of this slide, if we have really high pressure on the left side of the heart, remember this is going to back up into the lungs. If we have really high pressure on the right side of the heart, this is going to show more with distension of neck veins. So kind of some of those symptoms of congestive heart failure there. The cardiac cycle. So what I want you to do for this slide is turn over to page, I gotta find it here. I think I skipped it. Page 462. And you'll see that this image on page 462 is really great at explaining what is happening during diastole and what's happening during systole. So diastole is the filling of the ventricles. Systole is that big squeeze of the ventricles and pushing that blood out into the rest of the body. So there are some certain times that we may be documenting some sounds that we hear, whether the sound happens during diastole or during systole. And so normally we're just going to hear S1 and S2 and that's it. We're not going to hear any other unfamiliar sounds. But if we hear some unfamiliar sounds, sometimes we will use the timing there of during diastole or during systole to kind of describe when that happens. Also on this same page, if you look at the very bottom, you can kind of see that electrical conduction of the heart and how that correlates with what's happening in the heart during systole and diastole there too. So during diastole, the ventricles relax and they fill with blood, and at the very end of diastole, the atrias contract and push that last little bit of blood into those ventricles. And then we'll look at systole next. So during systole, the pressure becomes so high in those ventricles because it's trying to squeeze that blood out that the mitral and the tricuspid valves, those close. Those are those AV valves. That's going to be the very first heart sound that we hear is the S1, are those AV valves slamming shut from that pressure in the ventricles. And then for a brief moment, all of the valves are closed and the ventricle walls contract, and then it's going to push against those semilunar valves and push all of that blood out. So once again, the heart sounds that we hear are S1 and S2. We usually hear those through a stethoscope directly on the chest wall, not through any clothing. Sometimes though we'll hear some extra heart sounds such as S3 or S4 and possibly some murmurs. So the first heart sound, S1, is the AV valves closing. Remember those doors kind of slamming shut from the pressure that's building in the ventricles. And this is the very beginning of systole. So what we hear is mitral sound first and then tricuspid, but they kind of just go together as one sound. And so we describe that as S1. And usually we can hear it over any part of the pericardium, but it is going to be the loudest at the very tip of the heart there at the apex. The second heart sound, S2, this is when the semilunar valves close at the end of systole. So we're going to be able to once again hear that all over the pericardium, but this one is going to be heard best at the base of the heart. S3 is a third heart sound. It's an extra heart sound that we don't normally hear, but there are some vibrations that we might be able to hear. If our ventricles are resistant to filling, this is when we might hear that S3. But remember, this is not a normal sound to hear. It is pretty quiet if you do hear it, and it happens just right after S2. And of course, the next one, S4, is a fourth heart sound at the very end of diastole. And once again, this is still kind of related to those ventricles being resistant to filling with blood. So the atria contracts and pushes the blood into a ventricle that maybe is not real accepting of that blood, and we can hear just a little vibration. It's probably the hardest sound to hear, and we don't normally even hear it. So it is an extra heart sound that we don't typically even hear. Now murmurs, this is blood circulating through usually valves that are having some regurgitation, or we could just have some turbulent blood flow within the heart. And typically a murmur is just a sign of a diseased valve, and we'll hear kind of an extra swishing sound or a blowing sound that's not that nice crisp S1 and S2. So some different reasons we might have a murmur. We have a flow murmur because we have increased velocity. Viscosity of the blood decreases, so in anemia we might hear a little bit of a murmur. Usually the reason we hear that though is defects in valves. So that's going to be the main reason we hear a murmur, or those defects in valves. So this is how we document sounds that we hear. We are going to document frequency or pitch. It might be high pitched, it might be low pitched. Pretty relative because if we are hearing low pitched sounds, we need a really good stethoscope to hear them. But we can document the intensity as how loud or soft it is. Sometimes we have some heart sounds that tend to get muffled depending on what may be going on with our patient. The duration is either very short or maybe silent periods are longer, and that's going to be more related to heart rate, those types of things. And then once again, timing, which we've already discussed. Are these heart sounds happening during systole or diastole? So this is another just kind of A&P patho type of situation. The preload of the heart, this is a venous return that builds during diastole. And so what we're trying to kind of get with preload is it's the amount of blood that we can stretch into those ventricles. The more we can stretch those ventricles, the idea is the better squeeze it's going to have on pumping that blood out. So that's preload. Afterload is the amount of resistance the heart is going to get from pushing that blood out, how much harder it is to push the blood out. And it does overcome that difference. Those ventricle muscles are really strong to be able to do that. Okay, so now we're moving on from the heart to the neck vessels. And this starts on page 466. So the first thing that we talk about here is the carotid artery pulse. It is a very central artery, so it has a lot of pressure behind it. Really close to the heart. It happens right with that ventricle squeeze. And that is the pulse that we can feel there at the neck. And so characteristically what we see is a smooth, rapid upstroke. And that's going to be there on the bottom of page 466. As if we were to kind of see that pulse tracing, it's a strong pulse, and we can palpate that very easily. Jugular venous pressure and pulse. And remember, these jugular veins are unoxygenated blood going back into that superior vena cava. There's no valve there between the vena cava and the right atrium, so it's just dumping blood into that. So when we see that being distended when we lie the patient down, or even when they're sitting up, we know we've got something going on with the right side of the heart. Usually it's just failing and not pumping correctly. There are two jugular veins on each side of the neck. There are some larger internal jugular veins, really deep, that we cannot usually see. The external jugular veins is more superficial, and that's what we're going to be seeing if we see jugular vein distension, is with those external jugular veins. Arrhythmias, these are the presence of any type of heartbeat that we're not normally used to, so something outside of normal sinus rhythm. We can have supraventricular tachycardia, we can have ventricular arrhythmias. As a person ages, these become more likely. Tachyarrhythmias are not typically, and these are those fast heart rates, they're not as tolerated as well in older adults. Usually because their heart muscle is less compliant. It doesn't work quite as well as it used to. And then we see a lot of signs of confusion with them because their heart's unable to pump effectively that oxygenated blood around the body. So just some different cultural aspects to look at here, because there are some big differences. We do have several people in the United States, 1 in 3 actually, have one or more forms of cardiovascular heart disease. That's astronomical. That's huge numbers. And we see this as a result of different genetics that play a role, environmental factors, lifestyle factors. And so we're going to look at some of these factors here on the next few slides. Most adults have some sort of potential risk of having cardiovascular disease, but just because they're in a certain group, whether it be their race or gender, socioeconomic status, it does give them a higher likelihood in some cases of having coronary heart disease or cardiovascular heart disease. So men are more likely than women to have hypertension until age 45, and then it's pretty similar after that. And then once women reach 64, we have a higher percentage than men. So just kind of interesting there. Hypertension is 2 to 3 more times common in women taking oral contraceptives, especially if they are obese. And then hypertension is the highest among the African American race, and that is continuing to rise. We really haven't gotten a handle on that yet. So with that hypertension, prevalence is 41.4% is Black. And then you can see it really tapers off significantly after that for most other races. So just because of that hypertension, African Americans have a greater risk of stroke, heart disease, and kidney disease because of that hypertension. And of course, smoking plays a huge role in any type of cardiovascular disease. And you can see more risk factors and more incidences of cardiovascular disease in people that smoke than not. And more instances of myocardial infarction as well. Cholesterol, high levels of LDL gradually make people have a higher risk of MI and stroke. So the higher the cholesterol, the more likelihood they are of having an MI or a stroke. And we can see that Mexican American men and women are at the highest risk factor there, followed by African American and then white. Obesity is an epidemic in the U.S. Most people are overweight. 68% of people are overweight or obese. 73% of those are men. Our men are overweight, and 64% of women are overweight. So with this increase in obesity, we are seeing lots of different comorbidities, but you guys are probably going to see a lot of those in your clinical this semester and next module. Hypertension, high lipid levels, and of course type 2 diabetes. So looking at type 2 diabetes, anybody that has diabetes is at twofold greater risk of having coronary heart disease or cardiovascular disease. And you guys can read through some of these statistics and the genetic factors there. Also, when we look at just the fact of whether a person is a man or a woman, we do see some interesting statistics. Within the first year following a heart attack, women age 45 and older are 26% more likely to die than males, which is pretty interesting. And they're kind of attributing that to the fact that women have different types of symptoms, and so they may be delaying the diagnosis of heart attack, therefore causing more heart damage. Okay, so this is when we start to get into some of the assessments, and we are going to talk about the subjective data, but the objective data later on, there is another video for you to watch. So if you turn to page 471, this will point you in the right direction in the things that we are to be assessing. So there are 11 things listed here subjectively that we are going to talk to our patient about. So remember, during the subjective assessment, we are not putting our hands on the patient. This is just conversation. So first thing we're going to ask them is if they're experiencing any chest pain or tightness. If they are, we have some follow-up questions here that we need to ask. What we do need to be thinking about while we're asking these follow-up questions is that chest pain is a really important cardiac symptom, and usually it's because the heart just can't keep up with the demand of the body. So those are some things that we need to be asking them about. When did it start? Where is the pain? Describe it for me. And then, of course, when does it happen? Is it brought on by activity or rest? Some other things that we're going to be looking for with this is if they are squeezing their hand kind of over their chest, that's kind of a sign to us that they are having some chest pain. So just some other things that we can observe for in our patient. Some follow-up questions here with chest pain. Any other associated symptoms, sweating, pallor, those are some things that we're going to be looking at, and shortness of breath. Those are pretty typical, but we also need to be looking at those because they may mask some other signs and symptoms. It might not be a heart problem. They might be having chest pain for another reason, usually a lung reason. And so if they're not having some of these other signs and symptoms, it may not be their heart. Also, we can ask them, is it worse by any movement, or is it relieved by resting or taking any type of medication like nitro? Shortness of breath, if they answer yes, lots of questions there to follow up with. And what we can chart on them, if they're having some shortness of breath when they're up and moving around, we can chart dyspnea on exertion or DOE. And we have to kind of chart that in a little bit different way as to when do they become short of breath. So is it just walking across the room? So we're going to have to document that as DOE after 10 feet of walking, which is pretty significant dyspnea. So some different things we can ask them: when did it start? How often do you have it? Does it come and go? Does position make it better? Does it awaken you from sleep at night? And typically, if they're woken up from sleep at night, it's usually a sign of heart failure. So the heart, while they're laying flat, has a tendency to kind of build up that extra pressure, causing shortness of breath. Some other questions we can ask them is about cough. Do they experience a cough? How long have they had it? Does it happen more in the morning or night? What type of cough do you have? Do we have mucus? No mucus? Blood tinged? Lots of questions we can ask around cough. We do want to be thoughtful that if they are having sputum production or blood in their sputum, usually that is a pulmonary disorder, but it could happen with mitral stenosis as well. Fatigue, and here's some questions we can ask them related to fatigue. Fatigue is one of the top symptoms for women having an MI. So that is something to keep in mind. And usually fatigue is related to the heart's inability to keep up or having that worsening cardiac output. And if we have that worsening cardiac output, that typically gets worse throughout the day. Worse at the evening times. If it's from anxiety or depression or any other maybe type of mental health disorder, that fatigue is going to be ongoing. We're not going to have times that we feel better or worse. We would just typically kind of have an ongoing fatigue. Some other questions we might be asking them about is orthopnea. Do they have to sit up when they sleep? Have they ever noticed any cyanosis or pallor? And then nocturia is related to needing to void at night. These questions are mostly centered around congestive heart failure, especially the orthopnea and the nocturia. We do have some questions we can ask them about edema, about swelling in their feet and legs. You can see those additional questions there. If it's dependent edema, usually that's caused by heart failure, and that's usually worse in the evening and then better in the morning after their legs have been elevated throughout the night. That edema is also bilateral, typically on both legs, if it's unilateral or only on one side, we may have a venous issue or a vein issue that's causing that, and it's not normally congestive heart failure. Some other cardiac history questions we need to be asking them about. The history of hypertension, high cholesterol, triglycerides. You guys can read these here. Rheumatic fever or unexplained joint pain as a child. These are going to tell us if maybe they have some risk factors for heart disease. And then if they in fact are a heart patient and they have a history, we're going to need to know when the last time they had all of their tests run, like EKGs, labs, other heart tests, stress tests, and those types of things. The other thing that we need to be talking about is the family history. And I think that you guys can see that here in the book as well. So hypertension, obesity, diabetes, coronary artery disease, or even relatives that died at a young age for no obvious reasons. Then we need to look at those personal habits, asking them about those modifiable cardiac risk factors. Nutrition and smoking are two major ones there. The other ones listed in this are alcohol, exercise, and medications. So these are things that we need to be talking to our patients about when they come in. And you can see there are some pretty specific questions underneath each of these criteria. We also do need to think a little bit about the aging adult during this class. And they're more just kind of follow-up questions. And usually an aging adult that has a history of heart disease has other comorbidities as well. And so there are several questions that we could be asking them. And they can go in lots of different directions. And lastly, in this chapter, I want you to take the time to watch the assessment video that's been posted as well within this list of videos / lecture to watch. So that will take you completely through the objective data and findings for the rest of this chapter.